Complex urinary symptoms and their relationship to pelvic floor health and rectal prolapse. Urination is a fundamental bodily function, essential for expelling waste products and maintaining fluid balance. When this process becomes challenging, painful, or changes from its normal pattern, it's referred to as urination difficulties. These difficulties can manifest in a wide range of symptoms, affecting both men and women of all ages, and can often be indicators of underlying medical conditions. It's important to understand that urination difficulties is a broad term encompassing various uncomfortable or abnormal urinary symptoms. These aren't diseases in themselves, but rather signs that something in the urinary tract, kidneys, bladder, prostate, in men, or even the nervous system, might not be functioning optimally. This document will delve into these complex urinary symptoms, exploring their common causes, including obstructive and neurological factors, the influence of medications, and the critical role of pelvic floor health. We'll also examine the diagnostic process and a comprehensive array of treatment approaches, recognizing the significant relationship these symptoms have with broader pelvic floor conditions like rectal prolapse. Common signs and symptoms that fall under the umbrella of urination difficulties. Dysuria, painful urination, a burning, stinging, or aching sensation during or immediately after passing urine. This is one of the most common complaints and often points to infection. Urinary frequency, the need to urinate much more often than usual, without necessarily increasing fluid intake. This can be bothersome during the day and disruptive at night, nocturia. Urinary urgency, a sudden, compelling need to urinate that is difficult to postpone. It often feels like you won't make it to the bathroom in time. Hesitancy, difficulty initiating the urine stream, even when the bladder feels full. There might be a noticeable delay before urine starts to flow. Weak or interrupted stream, the urine stream is not as strong as usual, or it stops and starts multiple times during urination. Incomplete emptying, a persistent feeling that the bladder hasn't been fully emptied, even after urinating. Urinary incontinence, involuntary leakage of urine. This can range from a few drops to a complete emptying of the bladder and includes various types like stress incontinence, leakage with coughs, sneezes, and urge incontinence. Nocturia, waking up one or more times during the night specifically to urinate. Polyuria, passing an unusually large amount of urine over a 24-hour period. This is different from frequency, which refers to how often you go, not necessarily the volume. Oliguria, short/scanty urination, passing very small amounts of urine, often frequently, despite having the urge. This can be a sign of dehydration, kidney issues, or significant bladder obstruction. Hematuria, blood in the urine, which can appear pink, red, or cola-colored, or sometimes only be detectable under a microscope. Straining to urinate, needing to exert significant abdominal pressure to get urine to flow. Dribbling, leakage of urine immediately after finishing urination, or continuous light leakage. Recognizing these symptoms is the first step. Because they can indicate a range of issues from minor infections to more serious conditions, it's crucial not to self-diagnose but to seek medical advice if you experience persistent or concerning urination difficulties. Common causes of obstructive and neurological urinary symptoms. The combination of dribbling, urinary incontinence, incomplete emptying, hesitancy, and a weak or interrupted stream strongly points towards conditions that either block the outflow of urine from the bladder or disrupt the nerve signals controlling bladder function. These symptoms suggest that the bladder is struggling to empty effectively, leading to overflow, incomplete voiding, and difficulty controlling the flow. Key causes that can manifest with these 5 symptoms include benign prostatic hyperplasia, BPH, enlarged prostate, in men. How it causes symptoms: as the prostate gland, located just below the bladder and surrounding the urethra, enlarges with age, it can compress the urethra, obstructing urine flow. The bladder then has to work harder to push urine out. Why it causes these 5 symptoms: the obstruction directly leads to hesitancy, difficulty starting, weak or interrupted stream, and straining. Because the bladder doesn't empty completely, there's incomplete emptying. Over time, the bladder can become overstretched and weakened, leading to dribbling, overflow incontinence, and general urinary incontinence as it can no longer hold urine or contract effectively. Urethral stricture, in both men and women, though more common in men. How it causes symptoms: this is a narrowing of the urethra due to scar tissue, inflammation, or injury. Like BPH, it creates an obstruction to urine flow. Why it causes these 5 symptoms: the narrowed pathway directly results in hesitancy, weak or interrupted stream, straining, and incomplete emptying. The obstruction can also lead to pressure buildup, potentially causing dribbling and urinary incontinence as the bladder becomes overfilled or loses its coordinated function. Neurogenic bladder. How it causes symptoms: this condition arises from damage to the nerves that control bladder function, due to conditions like stroke, Parkinson's disease, multiple sclerosis, spinal cord injury, or diabetes. The brain and bladder can't communicate effectively, leading to either an overactive bladder, contracting too often, or an underactive/flaccid bladder, not contracting enough or at all. Why it causes these 5 symptoms: with an underactive neurogenic bladder, the bladder muscle, detrusor, may not receive the signal to contract strongly enough to empty, or the sphincter muscles may not relax. This directly results in hesitancy, a weak or interrupted stream, incomplete emptying, and severe urinary retention. When the bladder becomes severely overfilled and cannot empty, it leads to overflow incontinence and dribbling. Conversely, neurological conditions can also cause detrusor sphincter dyssynergia, DSD, where the bladder contracts while the external urethral sphincter contracts simultaneously. This creates a functional obstruction, leading to similar obstructive voiding symptoms and retention. Chronic urinary retention can be caused by various issues. How it causes symptoms: this is the inability to completely empty the bladder, which can be acute, sudden, emergency, or chronic, develops over time. It's a consequence of the underlying causes mentioned above, or other factors like certain medications, severe constipation, or a weakened bladder muscle from prolonged overstretching. Why it causes these 5 symptoms: the core problem is the bladder not emptying. This directly causes incomplete emptying. As the bladder fills beyond its capacity and muscles become weak, it can lead to dribbling and overflow incontinence. The struggle to empty can also cause hesitancy and a weak or interrupted stream. Pelvic organ prolapse, in women. How it causes symptoms: when pelvic floor muscles and tissues weaken, organs like the bladder, cystocele, or uterus can drop and bulge into the vagina, creating a kink or obstruction in the urethra. Why it causes these 5 symptoms: the anatomical obstruction can lead to hesitancy, a weak or interrupted stream, and a feeling of incomplete emptying. Depending on the type and severity of the prolapse, it can also contribute to various forms of urinary incontinence and dribbling. Weakened or dysfunctional bladder and sphincter muscles, beyond neurological causes. How it causes symptoms: while neurological issues are a major cause, the muscles directly involved in urination can also become weak or uncoordinated due to aging, chronic bladder overdistension, from long-term obstruction, muscle disease, or as a result of pelvic floor dysfunction. Detrusor muscle, bladder muscle: this smooth muscle in the bladder wall contracts to push urine out. If it becomes underactive or acontractile, unable to contract effectively, the bladder cannot empty properly. Urethral sphincters, internal and external. These ring-like muscles control urine flow. The internal sphincter is involuntary, and the external sphincter is voluntary. Why it causes these 5 symptoms? Weak detrusor directly leads to hesitancy, difficulty initiating a strong contraction, weak or interrupted stream, and incomplete emptying. If severe, it results in overflow incontinence, dribbling, as the bladder passively leaks when overfilled. Weak sphincters primarily cause urinary incontinence, especially stress incontinence, and dribbling because they cannot adequately close the urethra. Dysfunctional sphincters / lack of coordination. Sometimes, the external sphincter or pelvic floor muscles may not relax adequately during urination, or they may even contract when they should relax. This dyssynergia creates a functional obstruction, contributing to hesitancy, a weak / interrupted stream, incomplete emptying, and can lead to high bladder pressures and overflow incontinence. Associated conditions with weakened pelvic floor muscles, including rectal prolapse. The pelvic floor muscles support the bladder, bowel, and uterus, and are crucial for external sphincter control. Crucially, the presence of these 5 urinary symptoms themselves, dribbling, incontinence, incomplete emptying, hesitancy, weak / interrupted stream, can be an early indication of weakened pelvic floor muscles. If left unaddressed, this progressive weakening can predispose individuals to, or worsen, other pelvic floor disorders, including rectal prolapse, where part of the rectum slides out of the anus, or uterine prolapse, as the foundational support structures become compromised. A rectal prolapse, like other pelvic organ prolapses, can specifically contribute to urinary issues by altering the angle and pressure on the bladder and urethra, leading to obstructive voiding symptoms and sometimes difficulty completely emptying the bladder. This physical distortion can necessitate straining, which further weakens the pelvic floor and exacerbates both rectal and urinary symptoms. While these conditions are strong candidates for presenting with all 5 symptoms, a proper diagnosis always requires a medical evaluation, including physical examination, urine tests, and potentially more advanced urodynamic studies. Medications that can cause or worsen urination difficulties. Many medications, while treating one condition, can inadvertently affect bladder function and lead to or exacerbate urination difficulties. These effects can range from increasing urinary frequency to causing significant urinary retention. It's particularly common for certain drug classes to contribute to symptoms like hesitancy, weak stream, incomplete emptying, dribbling, and incontinence by altering bladder muscle function or sphincter control. Here are some common classes of medications and their potential impact. Anticholinergic medications. How they work. These drugs block the action of acetylcholine, a neurotransmitter that plays a crucial role in bladder muscle contraction. By blocking these signals, they relax the bladder muscle. Examples: many medications have anticholinergic properties, including some antihistamines, e.g., diphenhydramine/Benadryl, certain antidepressants, especially older tricyclic antidepressants like amitriptyline, some antispasmodics, used for bladder spasms or IBS, and some antipsychotics. Impact on urination. By relaxing the bladder muscle and/or tightening the bladder neck, they can significantly impair the bladder's ability to contract and empty effectively. This commonly leads to urinary retention, hesitancy, weak stream, incomplete emptying, and overflow incontinence, dribbling, because the bladder becomes overfilled and can't push urine out. Opioid pain relievers. How they work. Opioids can affect nerve signals to the bladder, reduce the sensation of bladder fullness, and increase the tone of the urethral sphincter, the muscle that keeps urine in the bladder. Examples: morphine, oxycodone, hydrocodone, fentanyl, etc. Impact on urination: they frequently cause urinary retention, hesitancy, weak stream, and incomplete emptying, which can then lead to overflow incontinence and dribbling if the bladder becomes too full. They can also contribute to constipation, which further impacts bladder function. Alpha-adrenergic agonists, e.g., decongestants. How they work: these medications stimulate alpha receptors, which can cause the smooth muscles in the bladder, neck, and prostate, in men, to contract, effectively tightening the outlet from the bladder. Examples: pseudoephedrine, Sudafed, and phenylephrine, found in many cold and allergy medications. Impact on urination: by increasing resistance at the bladder outlet, they can make it very difficult to start urination and maintain a strong stream, leading to hesitancy, weak stream, straining, and urinary retention. This can also contribute to incomplete emptying and subsequent dribbling/overflow incontinence. Calcium channel blockers. How they work: used primarily for high blood pressure and heart conditions, these medications relax smooth muscles, including those in the bladder. Examples: amlodipine, nifedipine, verapamil, diltiazem. Impact on urination: by relaxing the bladder detrusor muscle, they can reduce its ability to contract forcefully, leading to hesitancy, weak stream, incomplete emptying, and urinary retention. This can then cause overflow incontinence. Sedatives and muscle relaxants. How they work: these drugs can cause generalized muscle relaxation and decrease awareness, affecting the coordinated effort required for successful urination. Examples: benzodiazepines, e.g., diazepam/Valium, certain sleep aids, and muscle relaxants, e.g., cyclobenzaprine/Flexeril. Impact on urination: they can lead to hesitancy, weak stream, incomplete emptying, and incontinence by reducing bladder sensation and contractility, or by making it difficult for a person to respond to the urge to urinate, functional incontinence. Nonsteroidal anti-inflammatory drugs, NSAIDs. How they work: while generally well tolerated, high doses or chronic use of NSAIDs can affect kidney function and, in some cases, interfere with prostaglandin production, which plays a role in bladder contraction. Examples: ibuprofen, naproxen. Impact on urination: less common, but can contribute to urinary retention, particularly in older men with existing prostate issues. Medications for heart failure and/or hypertension. Many drugs used to manage cardiovascular health can directly or indirectly affect urinary function. Diuretics, water pills. How they work: these are a cornerstone of heart failure and hypertension treatment. They increase urine production by the kidneys to remove excess fluid and sodium from the body, thereby reducing fluid overload and blood pressure. Examples: furosemide, Lasix, hydrochlorothiazide, HCTZ, spironolactone, aldactone. Impact on urination: while their primary purpose is to increase urination, this can lead to increased frequency, urgency, and nocturia. In some cases, especially if not managed well, the sheer volume of urine can overwhelm the bladder's capacity and control mechanisms, potentially contributing to urinary incontinence, urge or overflow type, if the bladder cannot cope with the rapid filling. They generally do not cause retention, but rather increased output. ACE inhibitors, angiotensin-converting enzyme inhibitors, and ARBs, angiotensin receptor blockers. How they work: these medications are widely used for hypertension and heart failure to relax blood vessels and reduce the heart's workload. Examples: lisinopril, enalapril, Asaze, losartan, valsartan, ARBs. Impact on urination: while generally well tolerated, a well-known side effect of ACE inhibitors is a dry, persistent cough. This cough, if severe, can significantly worsen or even induce stress urinary incontinence, leakage with coughing, sneezing, laughing, by increasing abdominal pressure on the bladder. While less directly linked to the other symptoms you listed, hesitancy, weak stream, incomplete emptying, dribbling, the cough-induced incontinence is a direct urinary side effect. ARBs are generally used as an alternative if ACE inhibitors cause cough and are less likely to cause urinary issues. Beta blockers. How they work. These drugs slow the heart rate and relax blood vessels, used for heart conditions and hypertension. Examples: metoprolol, carvedilol, atenolol. Impact on urination, less common than other drug classes, but some beta blockers can potentially contribute to urinary retention or worsen voiding symptoms, especially in men with pre-existing prostate issues. This is thought to be due to their effect on adrenergic receptors that influence bladder muscle tone. It's critical for anyone experiencing new or worsening urination difficulties to review all current medications with their healthcare provider. Sometimes, simply adjusting the dosage, timing, or switching to an alternative medication can significantly improve symptoms without needing more invasive treatments. Never stop taking a prescribed medication without consulting a doctor. Diagnosis of urination difficulties. Diagnosing the cause of urination difficulties involves a systematic approach by a healthcare professional to identify the specific underlying issue. Given the wide range of potential causes, including obstructions, neurological issues, weakened muscles, and medication side effects, a thorough evaluation is essential. The diagnostic process typically includes comprehensive medical history. Detailed symptom description. The doctor will ask about the exact nature of your symptoms, e.g., when they started, how often they occur, what makes them better or worse, if they are painful. Your descriptions of hesitancy, weak stream, incomplete emptying, dribbling, and incontinence are very important. Urinary habits. Questions about fluid intake, frequency of urination, day and night, urgency, and any history of urinary tract infections, UTIs. Medication review. A complete list of all medications you are currently taking, including over-the-counter drugs, supplements, and herbal remedies. This is critical, as many drugs can contribute to urinary symptoms. Past medical history. Information on existing conditions such as diabetes, neurological disorders, Parkinson's, MS, stroke, heart disease, prostate issues, for men, and gynecological history, for women, including childbirths, surgeries, and prolapse. Surgical history, any previous abdominal or pelvic surgeries. Bowel habits, information about constipation or other bowel issues, given the close relationship between bowel and bladder function and the pelvic floor. The mention of rectal prolapse would be a significant point here. Lifestyle factors, diet, fluid intake patterns, smoking, alcohol, and caffeine consumption. Physical examination. General exam, to assess overall health and look for signs of fluid retention or neurological deficits. Abdominal examination, to check for bladder distension, indicating retention, or tenderness. Genital examination, to look for any anatomical abnormalities, signs of infection, or skin irritation. Rectal examination, for men to assess the prostate size, texture, and tenderness, which is crucial in evaluating BPH. Pelvic examination, for women to assess for pelvic organ prolapse, e.g., cystocele, rectocele, uterine prolapse, pelvic floor muscle strength and tone, and any signs of inflammation or anatomical changes. This would be particularly important if weakened pelvic floor muscles are suspected. Neurological assessment, brief checks of reflexes and sensation that relate to bladder control. Urine tests. Urinalysis, a dipstick test and microscopic examination of a urine sample to check for signs of infection, white blood cells, nitrites, blood, hematuria, protein, glucose, or other abnormalities. Urine culture. If infection is suspected, a culture will be sent to identify the specific bacteria causing the infection and determine which antibiotics will be effective. Bladder diary, voiding diary. Patients are often asked to keep a detailed record over 24 to 72 hours of time and volume of all fluids consumed, time and volume of each urination, any episodes of leakage, their severity, and what activity triggered them, the urgency level felt before urinating. This provides objective data on fluid intake, bladder capacity, frequency, and leakage patterns, which is invaluable for diagnosis. Post-void residual, PVR, volume measurement. This test measures how much urine remains in the bladder immediately after the patient has tried to empty it. It's done either with a quick bladder ultrasound, non-invasive, or by inserting a catheter into the bladder to drain and measure the remaining urine. A high PVR indicates that the bladder is not emptying completely, pointing towards bladder outlet obstruction, a weak bladder muscle, or a neurological problem. This is a key test when hesitancy, weak stream, incomplete emptying, or dribbling/overflow incontinence are present. Urodynamic studies, more advanced tests. These are a group of tests that evaluate how the bladder and urethra are storing and releasing urine. They are often performed by a urologist or urogynecologist, especially when initial tests are inconclusive or before considering surgical options. Uroflowmetry measures the speed and strength of the urine stream. Cystometrogram, CMG, measures bladder pressure as it fills and empties, assesses bladder capacity, sensation, and detrusor, bladder muscle, function. Pressure flow study combines CMG with uroflowmetry to assess bladder muscle strength and outlet resistance during urination. This is particularly useful for distinguishing between obstruction and a weak bladder muscle. Electromyography, EMG, measures electrical activity in the pelvic floor muscles and sphincters during bladder filling and emptying, helping to diagnose neurogenic bladder or detrusor sphincter dyssynergia. Imaging studies, if necessary. Kidney and bladder ultrasound, to visualize the kidneys, bladder, and prostate, in men, for stones, tumors, or structural abnormalities. CT scan or MRI may be used to get more detailed images if tumors, complex anatomical issues, or neurological problems are suspected. Specialized consultations. Depending on the suspected cause, a patient might be referred to a urologist, specializes in male and female urinary tract issues, and male reproductive system, a urogynecologist, specializes in female pelvic floor disorders and urinary issues, a neurologist, if a neurogenic bladder is suspected, or a pelvic floor physical therapist, for evaluation and treatment of muscle weakness/dysfunction. The diagnostic process is tailored to each individual, aiming to pinpoint the exact cause of their urination difficulties to guide the most effective treatment. Treatment approaches for urination difficulties. Treatment for urination difficulties is highly individualized and depends entirely on the underlying cause identified through the diagnostic process. The goal is to address the specific problem to restore normal bladder function and improve quality of life. Approaches can range from simple lifestyle changes and exercises to medication or surgical interventions. 1. Pelvic floor muscle training, PFMT/Kegel exercises. For symptoms related to weakened pelvic floor muscles and issues with voluntary urethral control, pelvic floor muscle training, often referred to as Kegel exercises, is a cornerstone of conservative treatment. These exercises are particularly effective for addressing urinary incontinence, dribbling, and can improve aspects of hesitancy or incomplete emptying linked to poor muscle coordination or support. Which muscles they strengthen? Kegel exercises primarily target the pelvic floor muscles, which include the voluntary external urethral sphincter. These are skeletal muscles that you can consciously control. How it works: these exercises involve repeatedly contracting and relaxing the muscles that form the floor of your pelvis. Strengthening and coordinating these muscles helps improve the ability to voluntarily close the urethra, significantly reducing leakage, stress urinary incontinence, urge incontinence, and post-void dribbling. Provide better support for the bladder and other pelvic organs, which can alleviate issues related to prolapse. Enhance muscle coordination, allowing for more effective relaxation of the pelvic floor and external sphincter during urination, which can help with hesitancy and stream issues if these are due to paradoxical contraction, and stronger, more complete contraction to fully empty the bladder and prevent post-void dribble. Proper technique is key. It's crucial to perform Kegel exercises correctly. Many people mistakenly use their abdominal, thigh, or buttock muscles. A healthcare professional, especially a pelvic floor physical therapist, can provide invaluable guidance through verbal instruction, explaining how to identify and contract the correct muscles, e.g., imagine you are trying to stop the flow of urine or hold back gas. Biofeedback, using sensors, internal or external, to show on a screen whether the correct muscles are being engaged and with what intensity. This is highly effective for learning proper technique and tracking progress. Electrical stimulation. In some cases, mild electrical stimulation can be used to help identify and strengthen very weak pelvic floor muscles, especially when patients have difficulty initiating voluntary contractions. Consistency is crucial. Like any muscle exercise, consistency over several weeks or months, typically 6 to 12 weeks, is required to see significant improvement. Once learned, they often need to be continued as part of a daily routine for ongoing benefits. Two, other muscles and their management. While Kegel exercises target the voluntary muscles of the pelvic floor and external sphincter, the other crucial muscles involved in urination are primarily smooth muscles that operate involuntarily or are part of complex neural pathways. They cannot be directly strengthened through conscious exercises in the same way. Detrusor muscle, bladder muscle. This muscle, forming the bladder wall, contracts to push urine out. Its function is largely controlled by the nervous system. Strengthening/improving function. If the detrusor is weak, underactive bladder, it's often due to nerve damage, chronic overstretching from obstruction, or aging. Direct, strengthening exercises are not effective. Management focuses on treating the underlying cause, removing obstructions, e.g., prostate surgery. Medications. Some medications can help improve bladder muscle contraction. Bladder retraining/timed voiding, establishing a regular urination schedule to prevent overfilling and encourage more effective emptying. Intermittent catheterization. If the bladder cannot empty sufficiently, a catheter may be used periodically to ensure complete emptying and prevent complications. Internal urethral sphincter. Located at the bladder neck, this smooth muscle is entirely involuntary and plays a vital role in preventing leakage during bladder filling. Strengthening/improving function. This sphincter cannot be consciously exercised. Its function relies on proper nerve signals. Treatment for its dysfunction often involves medications, alpha blockers, to relax it if overactive, though this can worsen incontinence if not carefully managed, or other drugs that affect smooth muscle tone. Addressing neurological causes, if nerve damage is the root. Addressing muscle coordination issues, e.g., detrusor sphincter dyssynergia. When the bladder contracts against a non-relaxing sphincter, this is a neurological coordination problem, not a weakness issue in the same sense as the pelvic floor. Treatment often involves medications to relax the sphincter or bladder, or in severe cases, procedures like botulinum toxin injections into the sphincter, or even surgical interventions to reduce outflow resistance. Pelvic floor physical therapy can sometimes help with relaxation and coordination training. Three, lifestyle modifications. Beyond specific exercises, several lifestyle adjustments can significantly improve urination difficulties and overall bladder health. Fluid management. Adequate hydration. Don't restrict fluids, as concentrated urine can irritate the bladder. Drink enough water throughout the day. Timing. Limit fluid intake in the late evening, especially caffeinated or alcoholic beverages, to reduce nocturia. Avoid irritants. Reduce or eliminate caffeine, alcohol, artificial sweeteners, carbonated drinks, and acidic foods, like citrus, that can irritate the bladder and worsen urgency, frequency, and sometimes incontinence. Bladder training/timed voiding. This involves gradually increasing the time between bathroom visits to retrain the bladder to hold more urine and reduce urgency. It helps restore the bladder's normal capacity and control. Working with a healthcare professional or physical therapist is often beneficial to develop a personalized schedule. Weight management. Excess body weight, particularly abdominal obesity, puts increased pressure on the bladder and pelvic floor, worsening stress incontinence and potentially contributing to prolapse. Losing weight can significantly alleviate these symptoms. Dietary fiber and constipation management. Chronic straining during bowel movements due to constipation can weaken the pelvic floor and exacerbate prolapse and urinary symptoms. Increasing dietary fiber, drinking enough water, and using stool softeners if needed can prevent constipation and reduce strain. Quit smoking. Smoking is a risk factor for bladder cancer and can also worsen cough, which contributes to stress incontinence. Managing underlying health conditions. Effectively managing conditions like diabetes, which can cause nerve damage leading to neurogenic bladder, or neurological disorders is crucial for bladder health. Four, medications. Pharmacological treatments are often used in conjunction with lifestyle changes and exercises, targeting specific underlying causes or symptoms. For bladder outlet obstruction, e.g., BPH. Alpha blockers, e.g., tamsulosin, alfuzosin. These relax the smooth muscles in the prostate and bladder neck, making it easier to urinate and improving flow. 5-alpha reductase inhibitors, e.g., finasteride, dutasteride. These shrink the prostate gland over time, reducing obstruction, but take longer to show effects. For overactive bladder, urgency, frequency, urge incontinence. Anticholinergics/antimuscarinics, e.g., oxybutynin, tolterodine. These relax the bladder muscle, reducing urgency and involuntary contractions. Note, these can worsen retention, as discussed in the medications that cause/worsen section, so careful selection and monitoring are needed. Beta-3 agonists, e.g., mirabegron. These also relax the bladder muscle in a different way, often with fewer dry mouth side effects than anticholinergics. For urinary incontinence, especially stress incontinence, if exercises aren't enough. Estrogen therapy. For women postmenopause, topical estrogen can help strengthen urethral and vaginal tissues. To improve bladder emptying, if detrusor weakness is the issue. Though less common and often challenging, some medications, e.g., cholinergic agonists like bethanechol, may be used to try and increase bladder muscle contraction, but their effectiveness can be limited. Often, self-catheterization is more effective for severe emptying issues. 5. Surgical and procedural interventions. When conservative and medical treatments are insufficient, surgical or procedural options may be considered, particularly for structural problems or severe obstruction/prolapse. For benign prostatic hyperplasia, BPH. TURP, transurethral resection of the prostate, the most common surgery, where excess prostate tissue is removed. Newer minimally invasive procedures, such as urolift, RESUM, or laser procedures, which aim to reduce prostate obstruction with less invasiveness. For urethral strictures. Urethral dilation, stretching the narrowed urethra. Urethrotomy, incision of the stricture. Urethroplasty, surgical reconstruction of the urethra for more severe or recurrent strictures. For pelvic organ prolapse. Pessaries, removable devices inserted into the vagina to support prolapsed organs. Surgical repair, various procedures to repair and support the bladder, rectum, or uterus, often involving meshes or sutures to lift and secure the organs. For urinary incontinence, severe cases, especially stress incontinence. Sling procedures, for stress incontinence, a synthetic mesh or body tissue is used to create a sling that supports the urethra. Artificial urinary sphincter, an implanted device that acts as a new sphincter, typically for severe male stress incontinence. Bulking agents, injections around the urethra to plump up the tissue and improve closure. For neurogenic bladder/severe retention. Sacral neuromodulation, interstim, a device that stimulates nerves controlling bladder function. Botulinum toxin injections, into the detrusor muscle to relax an overactive bladder, or into the sphincter if it fails to relax properly. Urinary diversion, in very rare, severe cases where bladder function cannot be restored and is causing harm, e.g., to kidneys, surgery to divert urine flow, e.g., creating an ostomy. Six. Integrated management for complex presentations. When multiple urinary symptoms coexist, especially alongside other pelvic floor disorders like rectal prolapse, it often indicates a more global weakness or dysfunction of the pelvic floor muscles and their supporting structures. In such cases, a truly holistic approach is crucial. Diagnostic clue: the simultaneous presence of all 5 discussed urinary symptoms: dribbling, incontinence, incomplete emptying, hesitancy, weak/interrupted stream, and a condition like rectal prolapse strongly suggests significant weakness or incoordination of the pelvic floor muscles. Rectal prolapse, in particular, is a clear indicator of compromised structural integrity in the pelvic floor. Holistic solution: for such patients, after ruling out acute issues like infection or severe obstruction, pelvic floor muscle training, Kegel exercises, becomes a primary and foundational treatment strategy. This is because strengthening and retraining these core muscles can directly address the urinary incontinence and dribbling by improving urethral support and closure, improve the coordination of pelvic floor relaxation, potentially alleviating hesitancy and weak stream if they are due to paradoxical muscle contraction during voiding, support the bladder more effectively, aiding in more complete emptying. Concurrently help manage the rectal prolapse by strengthening the supportive muscles of the rectum. Multidisciplinary care: this scenario underscores the importance of a multidisciplinary team, including a urologist or urogynecologist for diagnosis, and critically, a pelvic floor physical therapist for expert assessment and personalized guidance on exercise techniques, biofeedback, and overall pelvic floor rehabilitation. While other treatments, medications for bladder issues, surgery for severe prolapse, may still be necessary, addressing the underlying muscular weakness provides a fundamental and often long-lasting benefit. Conclusion: urination difficulties are common but complex symptoms that can significantly impact an individual's quality of life. From issues like hesitancy and weak stream to incomplete emptying, dribbling, and incontinence, these problems often stem from a variety of underlying causes, including anatomical obstructions, neurological conditions, muscular dysfunctions of the pelvic floor, bladder, and sphincters, and even side effects from common medications. Importantly, the presence of specific urinary symptoms can serve as an early indicator of underlying pelvic floor weakness, which, if left unaddressed, may contribute to the development of other pelvic floor disorders like prolapse. Furthermore, when these 5 urinary symptoms, dribbling, incontinence, incomplete emptying, hesitancy, and weak/interrupted stream, present alongside conditions like rectal prolapse, it serves as a strong indication of significant pelvic floor muscle weakness and dysfunction, making targeted pelvic floor exercises a crucial and often primary component of effective management. Fortunately, a comprehensive diagnostic approach can pinpoint the specific reason behind these challenges. Once a diagnosis is made, a wide array of management strategies are available. These range from conservative measures like pelvic floor muscle training and lifestyle modifications to targeted medications and, when necessary, various surgical or procedural interventions. Effective treatment often involves a combination of these approaches, tailored to the individual's unique situation and the specific interplay of symptoms and underlying conditions. If you are experiencing any persistent urination difficulties, it's essential to seek professional medical advice. Early diagnosis and appropriate management can lead to significant improvement in symptoms and help you regain control over your bladder health and daily life, potentially preventing further complications.